So that's the quick run through. Just a reminder, when you start to speak, we're audio recording the session, so your questions and any comments and answers will be available through that audio recording, and we can't answer policy questions. The ministry has contact people to answer policy questions. Our focus here is answering questions related to how we and others can help to get teams farther faster, and the focus of this conversation today probably more on how can we work with the research community, with local patient partner leaders and others to really help teams get where they need to get to as efficiently as possible. So questions, comments? Carrie, any online yet? No? Okay. So folks who are here in the room, and then we'll go back to the online, any questions or comments about teams, how RISE fits in, how you can contribute, what the needs are now? I covered a lot of ground very quickly. Yeah, do you mind just turning on the mic? It should turn red. There we go.
I'm happy you cover the fact that there are many primary care providers who are curious of what's going on,
Yep.
Have not been included in the first round that went out, know that more work is being done in different parts of the north, and have no idea how to connect. So at this point, there's curiosity, there is a certain amount of willingness to try something new, but don't know where to turn to.
So absolutely essential. I can't answer the question in terms of where Sudbury is, but from the last conversation, it seemed that people are aware of the challenge and know that they need to start to far more effectively engage primary care providers in the community. But one of the things we were talking about was doing as best you can in each step of the process. So October 9th is looming. How do you have the most meaningful engagement you can in that limited time while signaling that nothing is a done deal? This is going to be incremental. So once the full application is in, we can keep working on it. If you're approved to move to the next stage, keep working on it. But the key thing, if I come back to this slide, is the trusted relationships. Every step of the way, it needs to be done in a way that connects with those primary care providers and helps them understand that this is a long-run game that's only going to be successful if people can trust one another.
Okay, and the second has to do with people who are not necessarily Ministry of Health funded, but works within the determinants of health. Mm-hmm. And when you talked about specific segment of the population, you name, like homelessness and seniors who are not socially connected. Yep. There are agencies, mainly in the social services and not-for-profit, that do this. They also are curious about what is going on and don't know how to connect.
Yep. So again, I can't speak to the specifics of the local community, but we are seeing teams that from the very beginning have brought in those stakeholders in the broader health and social services space, even though for now the ministry is talking only about a budgetary envelope that is focused on things that the Ministry of Health pays for. But you can go to a community like Hamilton and you will see around the table the city government, where they have integrated the entire human services budget, and they're sitting there at the table saying, if it turns out housing is an issue, we'll bring our supportive housing dollars and our knowledge of housing to the table. If it turns out it's about disability or Ontario Works or some other program, we have frontline service providers who we can bring to the table. So I would encourage every team to think about how do you bring them in early, even though in the short run, the funding envelope will not include them, and no decision has been made whether we'll include them in future. But they're absolutely essential players if we want to work on some of these social determinants of health, housing, social services, and so on. So what we're telling people is bring them in. Doesn't matter what the signal is now. They're going to be absolutely critical to the future.
Okay, if you could define for me what you mean by bring them into what,
into
where,
the process.
when?
So if I go back to the leadership infrastructure slide,
Yep.
When I mentioned before this group, so if I think about some teams, they have some teams call it a partnership council. One that pops into mind has 24 members. That's every organization in the community that wants to be part of the team going forward. One of those team members is the city manager. So that individual has, over the years, built up an integrated human services budget, so that they get funding from multiple different parts of government, put it all together, and they're there as a full member. So when major strategic decisions are made, they have a voice in them, and then they have to go back to their regional board of health to bring counsel along in the process, but they're sitting around the table with 23 other heads of organizations making those decisions. Then a level below them, they have someone who really knows the operations of how housing and everything works from a city angle, and they're sitting around the second committee, the more operationally focused. So when I say bring them in, I mean bring them into this high-level table making strategic decisions and the table around the operational leadership. And then when it comes to working groups, if one of the working groups is priority populations and it turns out housing is important, we better get the frontline housing providers sitting around that working group table because they know what they can do in order to build the right package of services around people. Does that make sense?
Yes, it does. And so coming back to my primary care, we do have high volume of solo fee-for-service medical professional.
Absolutely.
So I couldn't see, like you say 24 people sat at the table. If we invite every solo MDs to add on, we'll have a team of 100.
For sure.
Yep.
So primary care, I agree with you. Primary care is a bit different in terms of representation around that table. So for more, let's call them traditional organizations that have a board and a CEO and so on, it's easier to imagine representation. For primary care at that table, it could be that there's one larger family health team, one family health organization, and someone else who is willing to be an intermediary between the broader community of primary care physicians that are paid fee for service. But it's about incrementally over time understanding what are the best ways to have those voices represented at these multiple levels of conversation. It's going to look slightly different in every community, but those primary care voices need to be at each of those levels. We're never going to have perfect representation. There's always going to be some primary care docs who say that person does not represent me, but let's over time iteratively try and get to a model where their voices are heard and they have a voice in shaping the future.
Okay, so coming back to what you said at the very beginning, and I can stop if there's anybody else that has a question. Coming back to what you said at the beginning, that we are now looking at referral patterns. Yep. And coming in, coming out to see what will be the geographical areas that, the teams will be based on a geographical area, or will they be based on referral patterns from physicians?
So I guess the quick answer is, in the short run, every team is going to need to decide what it feels it can put forward in the application. So I think most teams went in with a geographic basis, and now they're going to be receiving this map that shows referral and utilization patterns that might be different. So I think the hope is now teams just take a bit of time just to say, should we make adjustments in how we think about the group that we're accountable for? And does that have implications for which partners are invited to the table? Because it could be there's a neighboring community for whom we are likely in the long run to be accountable, but we're missing people from that community who provide services. So we're going to get those organizational leaders there. But this is incremental. So this is, what can you do between now and the full team application deadline? And then in future, it will iteratively evolve. But the current model is that the teams will cover off the full distribution of these referral and utilization networks, and that will be an iterative to and fro between the teams, and then the ministry saying, like no one in the province is covering this community or this population, how can we work with you to think about how they could be covered under your team?
So am I thinking too far outside of the box to say, so for Sudbury, you would have a geographical area that, for primary care, or for some of the tertiary care that happens at Health Sciences North, they would cover a way bigger area because everybody from the James Bay coast to Sault
Yep,
Ste. Marie
absolutely.
comes to Sudbury for some tertiary care, but then goes back to her area or everybody else's area for their primary care.
The attribution model is driven primarily by your connection to a primary care provider. So step one is, as an individual, am I rostered within a primary care provider? If I live in Parry Sound, but my primary care provider with whom I'm rostered is in Sudbury, I will be rostered in Sudbury. If I'm not rostered, then the next step is what primary care providers have I sought services from in the last 3-year window of time? And if most of the services I receive were in Sudbury, I will get attributed here. And then year to year, if I change my healthcare seeking behavior and I start to access primary care in Parry Sound, I will move as an attributed person to the team that is based in Parry Sound. So the idea is no restriction on patient choice. Patients continue to go wherever they go. Providers refer to wherever they refer, but the attribution is primarily about primary care. So we know that hospitals like Health Sciences North cover a huge chunk of the population, but they're also a local community provider. But attribution is primarily driven by that primary care connection.
Thank you.
But, you know, the big, I guess one big message is the attribution model is kind of sucking up a lot of airtime, and that's not, and I don't mean here, I mean in every conversation. But the important thing is just don't worry about the details of that. If you just focus in year one on the folks who are attributed to your population because they seek primary care in your community, that's good enough for year one. And then over time, you'll get more nuanced about covering people that are moving in and out. So the focus is meant to be a fundamental transition from a reactive approach to treating individuals to a proactive approach where you're accountable for a population. And in year one, you might not have your arms entirely around what that population is because referral and utilization are slightly different than geography, but you'll get 80% of the way there, which is more than fine in year one as we all learn and improve. Other questions or comments? Any questions online? So, yes.
Oh, there we go. Oh, sorry. So the question is, when you talk about providing support to local OHTs, what do you imagine the support looks like?
So initially, it's at this level of what Karen referred to as general proactive support. So we're listening very carefully, and we're being given insights from the ministry who are interacting with teams saying, it looks like people are struggling with X. So we're going to put on a webinar, or we're going to write a RISE brief, or we're going to do something specifically to address that need. But that's because so many teams are under the gun to meet a very particular deadline. Over time, the support could become more nuanced. It could be that 5 teams spread across the province say, we're all struggling with this piece of population health management. Can we have some targeted support to address this shared need? And then we would co-design a solution for them. So that's RISE, but we're one of several players. There's also within the Central Program of Supports ICES that can help with data analytics. There are other groups that will be brought on board over time that could bring things like coaching, other things. So this will grow over time. But initially, while so many teams are trying to move fast, we've emphasized the proactive, more kind of general supports.
Just as a follow-up to that question, if you're an individual with an expertise in a given community, what do you think are the ways that that individual should reach out to their local OHT and offer them something? Or
yep. So I guess the most important thing is find out whether you're in a community that has a team invited to full application, because that determines right now what you say and on what timeline you say it. If you're sitting in Sudbury, where the team has been invited to full application, they have very limited bandwidth to deal with anything other than doing what they need to get the full application in. So what I would do is I would look at the OHT, I would look at the application and I would say, oh, I can help with Appendix A on home care, and I can help with some other piece. So I will contact the local contact listed on the ministry website for that team and say, hey, I'm Joe Blow. Here's what I can help, how I can help with home care. If it's helpful to you at this phase, I'd be happy to do whatever would help. I can go to a working group meeting. I can do whatever makes sense. If you can't fit me in now, I'll remind you again at the next stage in case I can help in a more expansive process. If you're in a community or interested in working with other communities that have teams in development, you don't have the same time constraint. You could say to them, hey, I can help with building blocks 2 and 4. I have a lot of experience with population health management. I can help you with that. Let me know if I can come and, sit in on some of your meetings and whatever. So that's how I would approach it. It has to be very targeted for the teams that are facing the application deadline, but it can be more open-ended for others. Over time, what we're hoping to do is the matchmaking, because while there's a rich community of folks who can provide support in Sudbury and some other communities, that's not necessarily going to be the case in Espanola or Parry Sound or North Bay. And so we're hoping to make sure that over time people have different individuals that they can rely on. Yes.
So in reference to what you've just talked about, to be proactive, would we be able to get access to the data analytics so that we can prepare in advance information and resources, so if a time-sensitive request comes in, we'll be there to support them?
It's actually a great question. I don't know if they're planning to make them available. My experience with teams is that they're usually very welcome to share stuff. So sometime this week or next, if we use Sudbury as the example, they will get their full data package. You could write to the lead contact and say, I'm part of Craner or wherever you're based. A bunch of us think we might be able to help. Would you be willing to share your data analytics package with us? And then we can come back to you with some ideas about how we might be able to help. So the nice thing is that the ministry has provided contacts for every team, so you can write to them. And I guess I'd be surprised if folks weren't willing to share their data packages. There's nothing confidential about this. In the long run, this will all end up in the public domain because these are the types of metrics that every team is going to be held accountable for.
Okay, thank you.
Other questions, comments? Anne?
My question is actually about governance, and I'm wondering how much support there is for novel ways of doing governance, because I think you mentioned 3 ways, and they're somewhat conventional, and other models of governance might include the patient and family voice better, which would address the ultimate goals.
Yeah, so, I think, so our group is trying to provide kind of broad-based support, but the ministry is actively exploring what complement of other supports will be made available, and there's a good chance that there would be support specifically in that space. So as I was saying in the last section, we've often given kind of a superficial listing of here's some examples of process, but we haven't dove into them in any detail. And you're giving an example of something else where there could be just very creative ways outside the box. So either those groups might bring it forward in future, or if you have suggestions, then let us know or post them in the OHT community of practice to get people thinking about them. So again, we have this broad-based sense of expertise. If folks know of exciting governance models, get them out there, get folks talking about them. So we think collaborative governance is a good overarching way of thinking about it to transition people in their thinking from the old governing of a single organization to governing multiple organizations concurrently. But there are infinite pathways to that endpoint, and if you have innovative models, great. The application form, just like the self-assessment, puts a lot of emphasis on patients, families, and caregivers being involved in governance, and they also give attention to primary care providers being involved in governance. So if your models really bring that out, especially the patient, family, caregiver stuff, I think people would be all ears to hear about tangible examples. What we've heard is don't pick the end state yet. Like, you don't have to settle on an ultimate model. Focus on those trusted relationships and be open to a range of models so that you make an informed decision eventually. But again, if your models can help people move in that direction, great. And if they can give them a sense of what the future may end up looking like, that's also fantastic. So either send them to us or post them in the community of practice. So we're out of time, but let me just check. Carrie, anything else with folks online? Okay, anything else with folks in the room? And we have half an hour till the next session ends. So for those in the room, we can say goodbye to our colleagues on WebEx. If you want to have any quick conversations here when we're face-to-face, we're happy to do that. So last call, any questions or comments for the